I just wanted to welcome everyone back. If you missed this morning, we had so many engaging research presentations. So I will share with you that if you missed anything that you want to see, please do visit the website. I do think we'll have it posted there. When, Maria?
Slides are posted. Most of the slides are already posted online. So if you go to the NAPA website and the August 3rd meeting material link, you'll see all the slides from today.
Thank you so much to everyone this morning, and we're going to hear from our federal agencies. We have so many federal agencies that are deeply involved in the Alzheimer's infrastructure, so I'm looking forward to hearing their updates and reports, and then we're going to work our way to legislative updates. So we've got a big afternoon ahead of us, and with that, I will turn it to Maria.
Thank you, Michelle. And we are actually going to start in alphabetical order, so I'll go first with ASPE. So we just have a couple of updates. So I don't see the slides loading. I'll wait a second. So while I'm waiting for them to load, so as you know, the National Plan to Address Alzheimer's Disease is updated on an annual basis. And this year we are really leaning into engaging the public to inform our update to the national plan. And so that's really what the highlights from our updates are today, just calling out some of that work that has been underway. So one of the things that we've done is we, in July, last month, it just ended, we hosted 5 listening sessions where we heard from caregivers, people living with Alzheimer's disease and dementia, researchers, advocacy groups, you name it. It was very, very enriching to hear from everyone. We had about 250 people across those sessions participate, and then we also have an RFI that's open right now where we are seeking input from the general public to share your experiences, opportunities for improvement, successes, anything that you feel would be, helpful for us to consider as we work towards updating the national plan. So if the slides don't load, it's fine. Basically what the slide shows were links where you could access that information. So like I said, the RFI is open right now, and so there's a link to that information. And then also on our website, we have information about the national plan to address Alzheimer's disease and everything that's going on with that. And then, of course, if you have any general questions or comments about anything related to the work that we do and the council does, you can email us at napa@hhs.gov. And with that, I will turn things over to the CDC with Captain Lustillo, or Lustilot, if I don't use the French pronunciation.
All good. Either way. Great. Thanks for having me. Wonderful morning. Thank you for the updates. I really enjoy hearing those. Just 3 brief high-level updates for us. Number 1, the activity related to building our largest dementia infrastructure bold cooperative agreement continues across 43 recipients at the state, tribal, local, and territorial levels. We recently had a Learning Action Institute that was held here in Atlanta with in-person participation. It was great to have people in-house to share their success stories and to connect as well as it relates to ongoing collaborations and future collaborations. In regards to future activities, there is a NOFO, or Notice of Funding announcement, that recently closed. We had 28 applications for this. It includes a combination of components for the National Healthy Brain Initiative, Public Health Centers of Excellence, and ADRD adoption accelerators. And so we're reviewing those applications now and anticipate distributing awards to at least 7 recipients later this summer. We're excited about that, and the link is in the slides as well for those that are looking for the archived information for more details. And last, the Behavioral Risk Factor Surveillance System, or BRFSS, is in the field right now for 2026. It includes data collection on cognitive decline and caregiver trends across a number of states in the U.S., and we're also planning for 2027 activities that would include the same modules for data collection for use by state and local providers as well. So that's our updates, and happy to take questions in the future. Thank you.
All right, thank you. Now we will turn to Dr. Sherry Ling with CMS.
All righty, thank you, Maria, and hopefully my slides made it in. If not, okay, wonderful. So because this committee is still relatively new, I just chose to provide one overview slide to illustrate what some of the CMS authorities are by way of statute. I'm not going to walk through this slide specifically, but suffice it to say the updates I'm providing today pertain to payment, quality in the acute hospital setting with extensions into post-acute care, also nursing home care, and with the guide model and a guide model update. So first, I wanted to, and this is a quarterly update, so just suffice it to say, we utilize every of the statutory authorities to try to support the care and services that are delivered to people living with dementia, their care partners, and also people who may be at risk of dementia. Without specificity, there's some work specific to Alzheimer's, but really writ large dementia care. So our update for the payment aspect of this is calling your attention to the 2027 physician fee schedule rule, in which we included a request for information on intensive lifestyle interventions to slow the progression of Alzheimer's disease. The link to this RFI is included at the bottom of the slide and is meant to really complement other RFIs that ASPE and other our sister agencies have put forward. Please do take a look at this, and it's an opportunity by way of providing public input that may give CMS logical outgrowth opportunity. It may not need to be specific to lifestyle interventions. It could be addressing an element of lifestyle interventions. It could be that there may be clarity needed about who delivers the care and services to what subpopulation, what should we expect. So many elements there that include an opportunity to opine on care plans. So it may be under the rubric of advanced care planning, but the intent of this is not just about a directive at the end of life, but to create an opportunity for better care planning and conversations between clinicians and the people who they serve, who are patients at the time that they are receiving care. These comments are due September 14th. So please, those comments give us logical outgrowth opportunity to finalize something beyond or different from what originally is proposed. So in addition, calling attention to the age-friendly attestation-based measure for hospital quality reporting. So this will not carry a label of dementia quality reporting, rather it is includes attention to the 4 M's. So what matters most to the patient or beneficiary, mentation, which includes cognition, and also better delirium detection, screening, and assessment and management, mobility, better medication management, and so these are and these are all mechanisms by way of quality reporting to address care needs of the people who are served in hospitals. It is our hope that over time these domains and elements will be integrated into the electronic health record, which will create an opportunity to be able to measure outcomes in ways that are better standardized across care settings, including post-acute care and also ambulatory care settings. And this builds on the Impact Act of 2014. More information is available by way of this link. And just to also acknowledge that although today's session was about research and we have attention to better clinical management and service delivery, we also are charged with and have an opportunity to improve care and outcomes for people residing in long-term care settings in nursing homes. So this is just to notify this audience about the risk-based survey, which is a mechanism for improving nursing homes oversight and to create efficiencies by using data to flag where nursing facilities or nursing homes may need a little bit more attention or a little less attention depending on how their performance has been over time. So this risk-based survey will be implemented on a national scale, and more to come on this. So the link appears at the bottom of the slide. So in addition, the final slide is just to highlight the CMS guide model that is guiding an improved dementia experience model, which is an 8-year nationwide initiative launched by our colleagues over in the Centers for Medicare and Medicaid Services, the Innovation Center that started in July of 2024. It is designed to be a comprehensive model of care that we hope will improve quality, reduce costs, hopefully both, but it is in process. We continue to follow the recruitment, engagement with stakeholders, and thus far we have 297 guide participants, over 5,500 guide practitioners, and more than 8,000 partner organizations, and serving more than 50,000 Medicare beneficiaries. So we track the progress of the uptake, who's participating and who is served, and just want to flag that our team member Sarah is here from the Innovation Center and will be available for any difficult questions that may come up later. So Sarah, thank you, and thank you for your work, and I'll close with that.
Thank you, Sherry. Now we will turn things over to Michael Budovich with FEMA. And I'd also like to acknowledge Dr. LaShonda Moy, who I think is somewhere in the audience, who also came in from FEMA. So, she just waved hi. All right, Michael.
Let's see here. Great. So it's great to be here. As you know, FEMA's role is to help people before, during, and after disasters, and that definitely includes people with disabilities, including individuals who have Alzheimer's and other types of dementia. That support is locally executed, managed by states, tribes, and territories, and then supported by the federal government. And we support communities through all aspects of preparedness, including preparedness response, through all aspects of the disaster, preparedness, response, recovery, and mitigation. With respect to what we've specifically done in the last 3 months, we formed a new FEMA Alzheimer's task force, which we're really excited about. That's going to specifically look at how do we meet the needs of individuals with Alzheimer's throughout those various emergency management related response efforts, through recovery, through mitigation, and in preparedness. And specifically, we're going to highlight the preparedness aspect, the training aspect. You know, FEMA does a lot of training for states, for tribes, for local communities, for emergency managers, systems across the country, for fire departments. And so our new task force is, made up of individuals who focus on individual assistance as part of our recovery program from the Fire Administration, from our medical division, and then from our disability integration program. And specifically, some of the things we're going to be looking at that we're currently analyzing is how could we make our current training programs better and improve them, specifically to meet the needs of people with Alzheimer's and their caregivers. What kind of training does the U.S. Fire Administration do? How could that perhaps be improved? what do our exercises look like with respect to transportation, relocation rights, all those sort of things that we train communities on, and then taking a hard look at our policies and practices and ensure that they include the needs of people with disabilities and specifically of people who have Alzheimer's disease and all aspects of how FEMA operates. And that includes the very first, interaction that individuals may have with us or with emergency responders, ensuring that people sort of are ready themselves with their caregivers to be as best prepared they can for a disaster should it strike. And we do have some guidance for responders and families and caregivers that's available. We also participate there with the ready.gov site, which specifically has information and tips for people who have disabilities, including Alzheimer's and other types of dementias as well. So those are some updates. We're excited about our new task force and happy to be here. Thank you.
Thank you so much. Next, we will turn to HRSA, Dr. Joan Weiss, who's participating virtually. Joan?
Thank you, Maria. So just a friendly reminder that our Geriatrics Workforce Enhancement Program, our grant recipients use the Institute for Healthcare Improvements Age-Friendly Health Systems 4M framework, What Matters, Medication, Medication Mobility as the foundation for training the workforce, the supportive care, and the healthcare workforces to deliver person-centered, age-friendly care to older adults. Next, we've been working with our HIV/AIDS Bureau because as the population of persons living with HIV/AIDS continues to age, there is a growing need to ensure they can age in place while receiving high-quality person-centered care. So one of our grant recipients is an example of this collaboration. The Johns Hopkins University Black partners with the HRSA-funded Johns Hopkins Age Education and Training Center to enhance care for older adults living with HIV through interprofessional education. And this training is granted again in the age-friendly 4M framework and promotes integration of geriatrics in primary care. It also emphasizes HIV and aging, cognitive health, care coordination, and the management of multimorbidity and polypharmacy to better meet the complex needs of older adults living with HIV. And then lastly, we were able to give a supplemental funding to our 42 Blacks in an amount of over $1 million to develop and deliver education on limbic predominant age-related TDP 43 encephalopathy and multiple etiology dementia. That's it, Maria. Thank you.
All right, thank you. And then finally, we will turn to NIH with Dr. Richard Hodis and Dr. Amy Bainey-Adams.
Thank you. Waiting for the slides to come up. There we go. Thank you. Well, in terms of findings over this past quarter, I do want to report what's shown here, the result of an NIA-supported analysis of the true costs, societal impact and costs of Alzheimer's-related dementias. This shows that with the 5.7 million estimated individuals affected by Alzheimer's currently, that support includes 5.2 million care partners, and the total cost of dementia you can see broken down here to a striking $818 billion per year this year. That's including costs that go beyond the medical care, but looks at such things as unpaid care, earning losses, and so on, just heightened on top of the human tragedy itself, the costs of Alzheimer's dementia. And then to talk about a couple of the findings over this past year, here's one that follows from the sort of thing we heard a little bit about before, about lifestyle interventions. Some of you may be familiar, some years ago, with the report of the Finger study from Europe and Finnish studies, followed now by the U.S. Pointer that was principally funded by the Alzheimer's Association, a randomized clinical trial that assessed individuals for their individual risk factors and then designed intensive multi-domain interventions at an individualized basis. The results indicated that there was a significant effect in reducing global cognition in high-risk adults over a period of 2 years. NIH, meanwhile, had supported 4 ancillary studies that already are bearing fruit. The first of them was one which has looked at imaging, the neuroimaging ancillary study, looking at both PET measures of amyloid tau and MRIs, and some of the results already published from that include the finding that structural intervention may enhance cognitive resilience, in particular with people with low hippocampal volume or elevated brain tau, and that lifestyle interventions attenuated changes in cerebrovascular MRI markers, but in particular in individuals under 70, but not at over 70, providing the kinds of insight into the sort of individualization and targeting of interventions at stages into individuals. The other ancillary studies still in progress are those functioning to investigate the neurovascular function, sleep, and microbiome. As we've heard a good bit about today and in previous times, there's been remarkable advances in blood biomarkers. Most of those antibodies or protein studies looking at individual of the proteins that are identified as part of the pathology of Alzheimer's-related dementias. This interesting report was one which looked at circular RNA profiles in individuals with Alzheimer's or without, and identified some 34 AD-associated circular RNAs that are predictive of disease progression. Some of the conclusions suggest that they may be, in fact, even more effective in early prediction than p-tau217, pointing to the diversity of markers that are available to us and that are going to be important in future diagnosis of Alzheimer's and mixed pathologies. Just to summarize the way in which our summits, which occur, as you know, in cycles with 3 summits every 3 years, Alzheimer's Summit, Alzheimer's-related dementias and caregiving. This, the result of the 2024 Summit on Alzheimer's Research, but they generate recommendations. Those recommendations take the form for us of milestones that go into our national plan for AD research, illustrated here just by category. So these then, for each of these individual categories, specific milestones for each of those milestones, success criteria and ways in which we can track progress and commit the funds that we have available as appropriated to these areas of priority. And I'd like to turn now to Amy.
Thank you so much. And I appreciate the opportunity to talk a little bit about how the National Institute of Neurological Disorders and Stroke collaborates with NIA in moving forward research to address Alzheimer's disease, and particularly the related dementias, which fall within our mission space. So much of our collaboration with NIA is directed at basic science, where we can identify aspects of early disease progression which will lead to later therapeutic targets. So today I wanted to talk to you a little bit about an exciting discovery that came from a multidisciplinary team spanning 9 institutions in 4 states, and it includes international collaborators in the UK. So they're addressing a problem with TDP43. So we've heard a lot about amyloid and tau, but TDP43 is another protein that mutations that affect this protein can lead to Alzheimer's disease and related dementias. So this protein is usually in the nucleus, which sort of houses the cells, all of the cell's genetic information, and there it's involved in gene processing and RNA processing in particular. So the mutations that affect this cause it to cause TDP-43 to accumulate in the cytoplasm. So it takes it out of the nucleus and it ends up in the cytoplasm. And once it's in the cytoplasm, it also starts to aggregate. So like many of the other proteins that aggregate in these dementias, TDP-43 is another protein that aggregates. So one of the really fascinating things that this team identified were short RNA sequences that act as chaperones. So these small sequences of RNA will bind to the TDP-43 in the nucleus and cause it to change its shape. So it turns out TDP-43 is flexible enough that binding this RNA changes it into a different shape. That shape is much more soluble, and it will return to the nucleus where it then regains its normal function. And we have seen this happen in human-derived neurons from patients who had a mutation where TDP-43 was affected. And critically, I just want to note that these little RNA molecules are recycled. So once they sort of fix the TDP-43 molecule and send it back into the nucleus, they're recycled back, and then they can help change another molecule of aggregated TDP-43 to a soluble form and move it back into the nucleus. So it takes very few RNA molecules to affect many TDP-43 molecules. So that's great because then the dosing, if this were to become a therapy, wouldn't need to be super high. And I also want to note that these small RNA molecules are very similar to antisense oligos, which are already in development in other disorders as therapies. So we're very hopeful that this one day will be
I had a quick
useful.
question about that. Is it related to APO3? Is this where you're seeing treatment for this with this protein, or is that something different?
It's not unrelated, but
Okay.
It's not exactly the same. Yeah, thanks. Okay. But thank you for the question. And the thing that I'm also excited to share is that the lead author of this paper just received her PhD. So she is now a doctoral student a full-fledged doctorate and moving on to continue to do research in this area. But I just want to emphasize that training the next generation of researchers is something that we all feel really strongly about, and we're happy to demonstrate their success here. And then I'll close with just a brief update on the National Plan to End Parkinson's Act. I'm bringing it up in this context for a number of reasons. Number one, this plan, this act was designed to be very parallel to NAPA. It is also responsible for delivering a coordinated plan to accelerate research, improve care, and enhance support for people living with Parkinson's and their families. There also is some overlap with NAPA, both in addition to Parkinson's disease. This addresses many of the related Parkinsonisms, some of which are also covered by the important work done here by this committee. So we work very closely with ASPE just to make sure that that overlap is synergistic and never duplicative. So the Parkinson's Council, we have been working hard to establish over the recent months, and the membership was fully appointed and onboarded and includes some overlap with excellent federal members here. And we had our first meeting June 29th, so that was a very exciting moment for us. We are moving forward rapidly, so we have 3 more meetings scheduled this calendar year. Right now, we have 2 opportunities for public comment that are open. One is we have public comment open for our next meeting. So that public comment closes August 10th. And then we also have a request for information that is out. That request for information is broader than any one particular meeting, but we are seeking broad input to help this council and inform its work as it develops its plan. I found out this weekend from some excited stakeholders that having 2 opportunities for public comment open at the same time is confusing. So I just want to apologize up front for that, but I just want to say it reflects our enthusiasm for and commitment to getting public comment, and we look forward to hearing from everybody early and often. Napa has been an extraordinary example, I think, of how public comment, both at the meeting and more broadly, has really informed the work of the council, and we want to learn from that example. So thank you so much. That's it.
Thank you. So we're now going to open it up if there are any federal agencies that wanted to give oral comments that didn't have slides. Otherwise, we'll move to questions. Sure, go ahead.
Hi, this is Teresa Bracchio from FDA, and I forgot to include a slide that on July 16th, the FDA approved the subcutaneous form of lecanemab for initiation of treatment for Alzheimer's disease. Previously, it had been approved for maintenance dosing, meaning you still had to have 18 months of IV infusions prior to using the subcutaneous form, but with this approval, you can patients can now be initiated on lecanemab with a subcutaneous administration.
Very exciting.
Jolie with IHS.
Hi, can you guys hear me okay?
You're a little low volume.
I'll lean in and talk a little bit louder. How about
Okay,
now?
that's better. Thank you.
Okay. Tell me if I'm yelling, like wave your hand because I can see you in there. So sorry I wasn't able to make it in today. Julie Crowder with Indian Health Service. Just as a reminder, IHS serves almost 3 million American Indian and Alaska Native people through our system of more than 600 facilities and urban Indian organizations. Big, large health system, but we still work very closely and are connected to the clinics, facilities, and communities that we serve. So one of our biggest priorities continues to be getting funding to our tribes and urban Indian organizations, including local healthcare facilities and clinics. Part of this goal is supporting tribal sovereignty and self-determination, and really recognizing that tribes and local programs know best for what's going to work in their own communities. So our grant programs, of which we have several now as of this year, also give us a really valuable testing ground. We can take some of the great research findings and best practices that we hear about, for instance, in today's meeting, and put them to work pretty quickly on the ground. It's a pretty fast, flexible, and responsive system because we have a great network of folks who are really invested in improving care in their communities. Also, I think we benefit, unlike some of our other federal partners, from advanced appropriations. And we also were part of a minibus that was passed earlier in fiscal year 26, and that allowed us to keep working without interruption. And that allowed us to keep our funding opportunities rolling and our training and our grant and evaluation work. Some of the big stuff in this quarter, as some of you I think on the listserv know, we released the CARES Notice of Funding Opportunity, which is open through September. We have two options, both of which are essentially standing up national resource center type entities, one of which is focused on caregiver support. We are also actively moving forwards with supplemental awards for new tribal epidemiology center grants. There are one for each service area, an epicenter for each service area, as well as one for urban Indian organizations. And they're really linchpins for research and epidemiologic data and support. We're currently reviewing those applications and hope to fund at least 4 tribal epicenters to do something related to dementia data surveillance or public health capacity. Another big focus has been for us and continues to be training of the workforce. We, in the last quarter plus, have offered 60 training sessions as of last week, not including the ones on July 31st. And those sessions have reached more than 500 healthcare staff. We have 6 different trainings for nurses, CHRs, dental providers, pharmacists, behavioral health, and other folks across the team. So have been really excited about the response and uptake with not much marketing, if you will, for those as we're sort of testing the waters in that space. We are also really excited about a soon-to-be-released internal data dashboard that's based on the 4 M's of age-friendly care. The focus of that dashboard is really for internal quality improvement and better understanding about what's happening both across our grant program as well as the Indian Health Service as a care provider as well. So that also was developed at congressional direction, which was interested in prevalence and incidence type data for us. We also have a very active grant program evaluation contract, and I think the piece that maybe is most interesting to that group is we are working collaboratively with an SME panel and those contractors as well as our grantees to develop some future clinical care measures that we think would be useful for our clinical programs as well as our grants. Not just creating more reporting for the sake of grants reporting, but like actual measures that our folks will be able to implement to know that they're making a difference. We, like many of our other colleagues, have also spent a lot of time in the last few months with the Raise Family Caregiving Advisory Council. I believe their report was passed just last week, or their plan, the new plan was just passed last week, or are making its way through that process. And we worked really hard to make sure that the explicit needs of our communities were reflected in that work. We are, fingers crossed, also nearing the completion of the process to support 2 more models of care grantees, just waiting on some final award actions, and that would bring us to 18 clinics and communities actively receiving funding. Looking ahead, we really hope to focus on annual wellness visits as part of a practical way to do cognitive assessments. We already have multiple grantees who are already working in this space, and we want to be able to create some resources to support other facilities in that work. As always, our team continues to work with a small team and staffing limits, and we have to be pretty focused about our time and how we take on new work, but we're also super ambitious, and being able to see the fruits of our labor happen so quickly is pretty awesome. So appreciate all the updates today. The things that you talk about, like blood-based biomarkers and implementing them in primary care, are literally things we take away from this type of meeting and talk about how we're going to implement those tomorrow or next month or in the coming months. So appreciate you all and love the updates. Thank you.
Thank you. Are there any other federal agencies that want to give oral comments? Okay, if not, I think we have some time for questions from the non-federal members.
Any questions from the group, from our federal agencies? I just wanted to make a quick comment too. So we've heard a lot of research today. Then we heard from a great deal of federal agencies. We're going to hear more about policy. So you're seeing the convening. I think I can't reiterate it enough about what an important time this is in our world of Alzheimer's disease. For those of us, I'm looking at Rachel Conant, who have just spent decades in this space. This is a very, very exciting time. I said we're all sitting at the edge of our seat. So for those of us that have spent a lot of time in the space, to see this many federal agencies so actively engaged is so reassuring. So I just wanted to say many thanks to our federal agencies, having FEMA put together a task force like that. I'm hearing from Dr. Hodis and hearing about all the extra work that you all are doing is just, everybody should be so very encouraged. So from talking about research to our federal agency updates, it's been a very, very productive morning, now afternoon.
So we are a little bit ahead of schedule, which is not necessarily a bad thing. So Dr. Hodis and team, if you're okay moving to the joint presentation. So we're very pleased to have them present on the federal pipeline from research to coverage. So Dr. Hodis, Dr. Braccio, and Dr. Ling.
Yes, thank you for this opportunity. We thought it might be informative for the 3 of us, representing 3 agencies, to discuss with you what we discuss all the time among ourselves, the relative roles that we have in collaborating to the common ends and targets we all have of diagnosing, treating, preventing Alzheimer's and related dementias. So I'll start with slides which illustrate the kinds of progress that we've been making, and then turn to the way in which our agencies have contributed and will continue to contribute here. So if we just compare 2012 to the current 2026 in a variety of important areas, understanding disease mechanisms, one convenient, quantifiable metric is the number of genes or genetic variants we know are involved, 20 or so in 2012. Now clearly over 100 genetic regions that are identified, and importantly, the networks and characteristics which connect them. Diagnostics in 2012, we had amyloid PET for AD, which was a huge improvement over the time when the diagnosis was made really only at postmortem. We've added to that tau PET imaging, and then we've heard so much more about now commercially available blood tests, validated behavioral assessments as well, both manual, digital, and other. Disease-modifying treatments, well, we had none in 2012. As we've talked about here, in 2026, we're a couple of years into the identification of disease-modifying treatments. And then in terms of risk prevention, here too, we've heard a bit about some of the individual interventions and some of the multifactorial interventions like Pointer that we've talked about. Then care and caregiving, similarly, has been an area of research where research identified two among areas that are particularly promising, the collaborative care model and REACH, both now in practice being implemented with CMS's involvement as that as well. So this is the background to the kinds of things that have happened. Wanted to turn the way in which our three agencies play a role, something we're aware of all the time as we collaborate. So I won't introduce these in detail because you'll hear from each of the agents, but for NIH, funding of foundational research, both translational and clinical, is what's important. Some of the examples for the identification of disease-modifying lecanemab and donanemab, the final definitive trials, qualifying and registering trials, were funded by industry. NIH did not fund those. However, the basis for them in several ways in which I'll describe are importantly relevant for federal research and are emblematic of the way in which we attempt to have our missions in federal agencies combined with that of other sectors as well. So understanding amyloid biology at the most basic level, how amyloid forms, accumulates, and contributes to Alzheimer's, testing in experimental systems, animal model systems, and in vitro systems, all a part of the underpinnings that were supported by NIH and federal agencies. The clinical trial infrastructure, the development of trial procedures, cognitive and functional outcomes, site networks and recruitment so that when new interventions and candidates appear, we are not reinventing or starting from ground zero, but have important structures in place to accelerate the efficiency of these studies. Selection of trial participants. Originally, not so many years ago, we were talking about studies that recruited people as probable Alzheimer's, even in the absence of understanding what their underlying pathology was. Change, as I alluded to, with PET scanning, has now moved, and times we've been talking to the use of fluid biomarkers, which are much more accessible, awfully useful in recruiting people into trials and screening, reducing the costs and increasing the efficiency of this recruitment. And then measuring the effects as well, in addition to looking at some of the older measures of cognition, discovering newer ones, again, including digital measurements, voice analysis, some of these which allow us to track both people at risk and through the process of evolution and ultimately response to treatment as well. This continues with NIH supporting the development and testing of new candidates, target identification from genetic and other biochemical metrics, translational research program which take these findings and look them into preclinical trials and then eventually into clinical trials themselves. Some of the other dimensions, in addition to developing new candidates, are the use of drug repurposing, obviously great efficiencies in terms of having drugs that are already approved if they show promise for having relevance to Alzheimer's-related dementias as well, can accelerate their evaluation in that setting, and then the continued investigation of FDA-approved therapeutics in different combinations and in different stages of diseases. And finally, just to give an overview here of the scope of clinical trials being supported by NIH currently, non-pharmacologic, 148, pharmacologic trials, 63, and you can see the variety of targets, and that's what really this metric is meant to most emphasize. So among the 50 early phase or 13 late phase clinical trials, whereas amyloid is certainly among them, it is not a majority in any of these cases, and these were representative of the studies they'll be reporting out in the years to come, each with promise based on preclinical research, and each with a promise of addressing the components, what we now know to be the complex pathologies underlying dementias. Now I turn to our FDA colleague.
All right, thank you. I guess, Richard, you have control of the slides. Can I just tell you when to advance? Okay, we'll leave it here for a second. So, hi, I'm Teresa Bracchio with the FDA. I think most people recognize that we have a mission at FDA of protecting the public health by ensuring the safety and efficacy of human and veterinary drugs, biological products, and medical devices. However, it may be less appreciated that we also have as one of our objectives to advance public health by speeding innovation, to make medical products more safe, effective, and affordable, and by also ensuring that the public gets accurate and science-based information that they need to use these medical products as well as foods. So we have 3 main medical product centers at FDA, and I realized this morning after I haven't updated this slide lately because I have the Center for Food listed, but that's now called the Human Foods Program, so you can just mentally change that. But that's not my focus today. Today I'll talk about the Center for Drug Evaluation and Research, which is where I work, Center for Biologics Evaluation and Research, which we also call CBER, and the Center for Devices and Radiological Health, or CDRH. In CDER, we primarily oversee the development of small molecules, monoclonal antibodies, therapeutic proteins, and also we do have some diagnostics in our center with imaging agents like the amyloid PET agent. And then in the biologics group, CBER primarily handles cell and gene therapy products, tissue products, blood products, and vaccines. So any vaccines that would be in development for Alzheimer's would be handled in that center. And then in our Center for Devices, there are some therapeutic devices and diagnostic devices for Alzheimer's and related diseases, but they have a major role in overseeing the development of in vitro assays, such as the blood-based biomarkers that we've talked about today, as well as specific imaging modalities that are, which I'll distinguish from the imaging agents that are things that are administered like radioligands or contrast agents that CDER manages. CDRH handles the actual imaging products. So we do have a number of FDA approved or cleared medical products for Alzheimer's disease. We discussed today the amyloid-directed monoclonal antibodies, lecanemab and donanemab. The acetylcholinesterase inhibitors have been around for going on 30 years now, for at least for some of them. NMDA antagonist memantine, there are some approved therapies for behavioral symptoms in Alzheimer's disease, such as brexpiprazole, and the most recently approved product, dextromethorphan and bupropion. And then I'll just note that not specifically approved for Alzheimer's disease, but suvorexant is approved for insomnia, and there is some description of use in patients in Alzheimer's disease in that label. And we've talked about a number of the diagnostic agents that are available, including blood-based biomarkers, cerebrospinal fluid biomarkers, and PET imaging agents. And as well, there are also some digital cognitive assessment devices that have been cleared or approved by the agency. Recently, Jeff Cummings issues an update every year where he describes the current drug development pipeline. This quote is from this last year in 2026, that there are currently 158 drugs in 192 Alzheimer's disease trials. But I will just note that that's likely an underestimate because he bases this on clinicaltrials.gov, which is perfectly appropriate to use. However, that does not capture phase 1 clinical trials. So I did a rough estimate earlier this year looking through our database of just commercial investigational new drug applications, and I got a number just in CDER of around 180 or so, and that doesn't include anything in CBER or the devices group. And that also doesn't include research INDs for investigators, which is a substantial amount of work for us. And this is just a rough diagram of the medical product development cycle, which can roughly apply to drugs, biologics, as well as devices. And FDA is really engaged in all steps of this process. In the earliest stages of discovery, we have a limited role. We mostly are engaged if there's pre-competitive efforts. But as candidates get identified for moving forward into clinical studies, FDA becomes engaged. Prior to an IND submission, we certainly review the IND or IDE, which is the device exemption. We will review those and allow them to move forward. All throughout stages of clinical development, we are engaged and meet with investigators and sponsors of these applications up till the point of marketing application, and then even after in the post-approval setting, we remain engaged. So I described a few of these key review activities that we engage in. So as I mentioned, throughout the product development life cycle, we provide advice to sponsors of drug or device applications and advise them on the type of data that would be needed to support initiation of clinical trials, or if the clinical trials are already underway, advice on the types of clinical outcome assessments or safety data that would be needed to support a future marketing application. While the trials are going on, we monitor them for clinical safety. At the time that either an application for an investigational new drug application to initiate clinical trials or the time of a marketing application, we will conduct a regulatory assessment of the products to either support initiation of trials or a future marketing application. And then, as I mentioned, even after approval, we continue to conduct surveillance for safety in the post-approval setting. And I will say, as I noted with numbers on the prior slide, we do have many active product development programs across our centers for Alzheimer's disease and related disorders. And therapies may target symptoms or underlying disease pathology. And we also have some that target causal genetic variants and genetic forms of Alzheimer's disease or related dementias, such as Down syndrome that was mentioned earlier. I will say the things, I don't have this on the slide, but I will note a few of the things that are not in our purview, which is one is that we do not regulate drug prices, which is a common misunderstanding. We do what we can to facilitate getting drugs to the market so that hopefully that will increase competition. However, we do not actively regulate drug pricing. And we are not a major funder of research. We do fund some research. We do have some funding, but we are not like the NIH in that regard, where that is their main purview, and ours is it's a little extra that we do, and we get some funds for research. And also, importantly, we do not regulate the practice of medicine. So while we approve drugs, prescribers are able to use drugs appropriately as they see fit. And then on my last slide here, I'll get to this is more to the innovation side of things, how we help to support innovation. And generally, this is through our engagement in pre-competitive efforts and regulatory science initiatives to address areas for opportunity to support current and future development. One example of this is a draft guidance for industry that we have on early Alzheimer's disease, where we discuss developing drugs for treatment and the use of biologically based staging of disease to help select appropriate clinical outcome measures given the stage of development. And the different potential approval pathways for either an accelerated approval or traditional approval. As I mentioned, we've also been engaged specifically in discussions around biologic staging of disease, as we feel that this is really essential to guide early intervention strategies for Alzheimer's disease. We do some of our own regulatory research. Most recently, we've been doing work on pooled data sets in Alzheimer's disease clinical trials for the monoclonal antibodies to look at both risk factors for ARIA and also sex-based differences in treatment effects. Most recently, Kevin Krutis from our group presented some of the safety analyses on risk factors for serious symptomatic ARIA at the Alzheimer's Association International Conference a couple weeks ago. We are also very engaged in a number of public-private partnerships, and notably the Critical Path for Alzheimer's Disease and the Accelerating Medicines Partnership for Alzheimer's Disease. And then finally, we are very engaged with the Alzheimer's disease community, with the patient community and stakeholders. We have a number of ways that we become engaged. In addition to attending scientific meetings, we will also be engaged in patient-focused drug development meetings and patient listening sessions. All right, I'll turn this over to Sherry Ling with CMS now. Thank you.
All righty. Thank you. Just checking sound. All right. So the perspective and information, much of this is background information of how CMS works, what CMS's authorities are, and just to say, we always revisit and start with what the mission is for the agency, and each administration refreshes the mission so that it best fits the agency's and department's priorities. And so this is the most recent mission statement, which is to ensure our most vulnerable receive high-value care by leading all payers and supporting providers. And providers can be include both facilities and clinicians across the care continuum. And as a refresher, the CMS scope is that the agency remains the largest payer for healthcare service delivery globally, and touches on the lives of approximately 1 in 3, and some estimates 1 in 2 Americans. And so, you know, the reach is quite broad, and over the years, the agency has been driving more towards value, delivering value by way of purchases made by way of policies. And so it is less a priority to focus on the volume of services that is delivered. Now, the challenge that we have, and this is something that has been a continued trend over time, is that the population served by Medicare and also Medicaid has become increasingly complex. So what appears here is a snapshot of the original Medicare population, which was also referred to as fee-for-service, from 2024. And the orientation for this slide is, it recognizes a bit of an eye chart. So if you can read the words, your eyes are good. But just to say, what appears on the y-axis here are individual chronic conditions. There are 21 such chronic conditions that are depicted here. I've actually put a red box around Alzheimer's and dementia, and illustrating that what appears on the far left in the yellow, and often you cannot see the yellow because it's so small as far as the percentage of the population of Medicare that's represented by that condition and that condition only. In the case of Alzheimer's and dementia, the percentage that has only Alzheimer's to dementia is 1% of all of Medicare. What appears in the orange is that percentage of the population that has 1 or 2 other conditions in addition to Alzheimer's or dementia. What appears in blue, which is 24%, that has 3 or 4 other conditions. And what appears in all the way to the right in the darker blue is the percentage that has 5 or more other conditions. So that, as it applies to the Alzheimer's population, is 64% of Medicare beneficiaries have 5 or more other health conditions. This is an important observation and an important understanding, because the Medicare statute actually is very distinct. The authority is distinct from that which FDA and Teresa just spoke of, which is the bar for FDA is safe, effective, and in the Medicare population, it is treatments and services covered by Medicare have to be reasonable and necessary, or said otherwise, also clinically useful. And that is a little different, importantly different, when you think about the people who are being served with the condition of dementia or Alzheimer's, as opposed to the focus on dementia alone without this context. So I did also want to mention that, you know, with the different Medicare policies, one of the authorities is for coverage of treatments and services. And remember that Medicare coverage also relies upon statutorily defined benefit categories. So earlier you asked about providing coverage and payment for artificial intelligence. So there is no benefit category for AI in and of itself. And where this, we observe this, we look for other ways, such as a service that's provided by a Medicare provider, whether it's a physician or a physician extender or other APPs that may utilize the service to provide the care that is perhaps informed by AI. That is a pathway to look at how could we connect the dots. And this is also an area of study or investigation that our access model in the Innovation Center is looking at, using technology to provide care and services, including a population of people with behavioral health needs. We have also inserted people with dementia into the behavioral health strategy because often it's difficult to tell if a beneficiary has depression or delirium and dementia or dementia. So just to be more inclusive than exclusive, that to explain how this works. So back in 2022, CMS covered under the category of coverage with evidence development by way of a memo, antibody therapies directed against beta amyloid. And just to explain what CED is, CED, coverage with evidence development, is a national coverage policy that one can arrive at, and if the evidence is promising, but not necessarily sufficient as it applies to Medicare beneficiaries. So that was the state in 2022, and the studies that are covered by way of CED have to be able to address specific questions that are outlined in the NCD, and these are the questions that you all who are developing the evidence have been hard at work trying to answer, not just to meet the coverage policy, but because these are important questions to answer. Who does it work for? What do we expect over time with treatments? And so, you know, this has been an area of focus. And with the evolution of the evidence, this has also shifted over time with continued focus on providing coverage, but in ways that do not necessarily require a randomized placebo-controlled trial, where real-world evidence can be utilized to answer the very questions that are being asked and hopefully answered with support of the policy. These are the 4 approved studies that were originally approved that included 2 registries in the spirit of real-world evidence. I will say, you know, with the continued coverage by way of CED, there remains opportunity to submit additional questions that may have arisen as you're answering the first questions. And also, as long as the interventions address amyloid, could address other things, such as tau. There was an exercise study that was at one time approved, so some of pointer work could have fit under these constraints. So we have provided guidance on CED, explicitly stating that the evidence need not come from a randomized placebo-controlled trial, and the policy continues to be updated over time. I did also want to flag, though, this is just one mechanism by which CMS actually supports evidence generation, evidence development. CMS is really more in a payer role as far as roles in HHS, but that said, can support evidence generation, not only by way of CED, but flagging for you that there is an investigational device exemption where studies, if registered in the NIH Clinical Trials Network, and also the Clinical Trials Policy permits CMS to pay for what is reasonable and necessary routine care and services in the Medicaid side. That's the different language in comparison to Medicare, which is reasonable and necessary. Pay for those treatments and services that would be expected in the care and keeping of individuals as they go through the study, providing the studies are registered as clinical trials on the NIH website, and that these policies can apply to, Randy, a while ago you asked me about, could this be a drug trial that may address a drug that is seeking expanded indication for something else? I think the answer is it's feasible to do. It need not be a device. So, there is the ability to be efficient in the funding in ways that still meet the Medicare statutory definitions. The last thing I will close with is that, and I forgot to add to this slide, there have been questions about how can CMS or Medicare incentivize enrollment in recruitment into clinical trials, because that is hard and very expensive. Back in the COVID time, CMS finalized several clinical practice improvement activity that is included in the merit-based incentive program to encourage and support evidence for practices that are being paid for and incentivized, or removing the disincentive now, because it is a penalty if you don't participate in a alternative payment program or in MIPS, that encourages recruitment and evidence generation by supporting the population-based applications that could result in new evidence that helps all of the work that we do over time. And so there are 4 different improvement activities, 2 of which actually address intellectual impairment, populations of people living with intellectual difficulties, disabilities, impairments, dementia, but not specific to Alzheimer's. But I urge you to take a look at those activities, which can be also helpful in support of evidence generation. And I will stop there. Over.
Thank you so much.
I just wanted to thank you all. I really enjoyed that presentation. They're keeping me highly caffeinated here. But thank you for hanging in with us for just a bit. I thought maybe we could take 5 minutes, maybe 5-10 minutes. We're running a little early, just for everybody to stand up and stretch.
Can I ask a question before you
No,
break?
of course you can, sir. Absolutely.
We had a brainstorming session from 12 to 1, aka lunch, and I asked Dr. Mike Rafi and Dr. Reese Sperling if they had a wish list for us in this room, and it goes exactly in what you just talked about. What would be the best mechanism inside NIH, CMS to fund biomarker testing for all patients with Down syndrome, because there's a 95% chance of them develop that, and create a pool of 100, 200, 300,000 people with biomarking testing that are available for all these dozens of clinical trials or hundreds of clinical trials. How could you fund a pool of people tested? Is that a registry? Again, we have all these brains, beautiful, in this room. How can we fund this opportunity? Because with that, I think we could, and that's not my opinion, is their opinion. I appreciate you sharing that. I'm sorry, exposing that here. That's why we're here. how can we fund that? To have a pool of 200,000 patients with, we know their ApoE4 status, we know their p-tau, we know their amyloid beta. How could we fund that? So we have this digital signature. Okay, this is my biomarker. Okay, how can we fund that? Start with you, Dr. Ling. You just talked to us about that, and maybe, I don't know, Dr. Holtz and others can jump on that.
So, okay. So I can start, but it's kind of backwards because I always defer to Richard as the evidence generator and the funder of research. I will say, however, that so everything that I just said about Medicare coverage applies to Medicare beneficiaries.
Yes, no, that's what we're talking about.
So are the people who you're talking about in the registry Medicare beneficiaries? That is going to be...
I would start right there, 65 and over, just simplify that. They're all Medicare.
So I'm thinking about, so remember, Medicare is not just a benefit that is defined by age, but also disability status.
Let's say they're all Medicare.
So if they fit under Medicare, then the policies I just mentioned are applicable. The CED, however, is defined already, so one would have to come up with either a new study or an extension of a study that could be proposed and addressed and reviewed by the Medicare coverage team.
I see Randy's itching too.
Yeah. So I have to jump in on this. So is there a way with Medicare, the coverage that you described with the CED or otherwise, a way to take the currently approved drug programs that are being tested, the FDA-approved drugs, and do what's being suggested for the population? Is there a way to use that system to screen people who are asymptomatic if they're Medicare beneficiaries and determine their efficacy in that trial?
Yeah, that's a really important question. So also, what I didn't mention, I'm glad you're asking about this, Randy, is so CED applies to parts A and B, that is hospital and physician services. Beyond that, if it is a drug, most drugs, if FDA approved and included in the Part D compendium, are coverable, but then it is not something that would be coverable by way of CED that applies to A and B services.
I see. So does it have to be? So how does that happen though? Do you get a new drug then that's not FDA approved, or no drugs would be allowed?
So even if it's a
tested?
drug, so Part D covers drugs,
right?
And so the pathway would be expansion of the CED authority into a space that is not constrained by A or B. That is, CMS is on the receiving end of those authorities.
Is that a decision of HHS or is that an act of Congress?
No, it would be Congress.
So only Congress could cover
new benefit
the ability...
categories, and yes, that is correct.
That's why I'm thinking, what if you just did a new trial so that you, I'm always the path of least resistance and...
Yeah, a new trial.
No offense to any members of Congress, but...
No, but never saying that there is, but so a new trial, the question is going to be, where does that new treatment fit in the statutorily defined benefit categories? And so paths could be, so if it's a new drug A or B, that can come in under CED through the regular processes, right? Mm-hmm. If it is a drug, though, then we lose the CED authority. So that would be a new benefit category application of CED to include drugs, which would have to be a congressional action. So hopefully that answers clear enough. I love your thinking, though, because you're thinking about how do we bring therapeutics quickly to people. And also, Ricardo, you're thinking about how do we create a resource that we can all learn from, right? Which is, how do these biomarkers work?
And enhance the speed of enrollment, right? Because I think a big part here is you show 192, and we have, again, I'm glad for that. This runs in the family. It comes very close to home, but it's 2 drugs in the course of many, many years. So I think quoting Dr. Sperling, and I love that term, it's a tsunami, right? It got a little bit blurred because of COVID, but now it's in our face again. A third of people over 80 is a lot of Americans. There's a lot of people all over the world. So again, I think speed, I think that's why we're here, right? So if we had a pool of people with this bio signature, it would help all clinical trials. So I think that would be something interesting to discuss, Randy, on our subcommittee.
So there's one other catch, okay, just so that you know, you understand the CMS statutory authorities. So CMS is not a funder of research. We work with our federal partners for that purpose. There's also, and we ran into this, we understood it by way of, globally, we are also running out of antibiotics. So could there be funding by CMS for the development of new drugs? The answer was no, because it doesn't exist yet. So just to say that, again, we have to work within CMS authorities to see what is feasible until we get new congressional actions, and we're not able to request those actions. But I'm sure Richard and also our colleague from Agency for Healthcare Research may have additional thoughts about how to fund what sounds like a cohort with biomarker funding biomarker collection that is closely tied with clinical outcomes and phenotypes that could perhaps also be gathered by way of real-world evidence so as not to create biases by the need to go beyond. How can we do this efficiently, being that people are getting care now and they're seeing clinicians now? So I will stop there and see.
I think it would be a good, and I don't know, Dr. Hodes, if you want it, but I think it's also a good topic for the research subcommittee, as you mentioned, Dr. Hanel, to deep dive a little bit more, because I can see it from a policy perspective, and then I'm seeing it from a funding perspective. So there's 2 different things that are going on in my head. But if for immediacy, I think you would have to drive it through an alternative door. That's why I was asking if it could be something new, if that makes sense. But anybody else want to comment quickly on that?
Well, just commenting, I think I'm saying nothing that most of the folks in the room don't know already, but what we are supporting, what NIH is supporting, for example, in populations at high risk that include Down syndrome or the autosomal dominant networks, those are populations in which NIH funds research. There are, if you will, registries of people who are exhaustively characterized in terms of clinical and biomarker phenotypes and are there for recruitment into clinical trials. It's not enough. It's not enough people. It's not enough of a population. But that's the precedent. If you're asking for populations beyond those that define high genetic risk, for example, how one might expand to accelerate eligibility and improvement in trials, I think that is something that in groups, including the research subcommittee, we're thinking very much about. But those are sort of, if you will, the models or prototypes for high-risk genetically defined populations in which we're doing things along the style of what I think is being asked about here.
Yeah, and just let me expand on that. I mean, we've gotten to the point in the scientific understanding, the medical certainty of what the effects of these drugs do, these class of drugs do. There are a number of other targets and other chances that they can and need to be taken, but these need to be taken in the general population. They can no longer be restricted to the highest risk category of people who will get the disease. In order for that to proceed, though, it's going to require a substantial amount of funding to launch the prevention and treatment trials. And if there's not currently a mechanism through CMS, FDA doesn't fund research, as we heard, then it sounds like it it needs to go through NIH or another mechanism for the funding to occur to allow prevention in Alzheimer's to reach that levels of cancer and other diseases. From my standpoint, it just seems to me that we're all poised to move forward on this, but there are some major limitations, and it's largely in funding. It's why one of our first recommendations of our subcommittee was an increase of funding to be able to do things like this. But I think we have to talk seriously about how are we going to get that done? Because the times are different now today than what they were just a few years ago. And if we don't make some concrete plans to do this, I just don't know that it's going to happen. And that's going to be a huge lost opportunity in this time. Let me give an example. The recent drugs were approved by the FDA, paid for by CMS. Our estimates are that they're reaching only about 1% of the entire population of people who could be treated today are being treated. We don't have the capacity, the systems, things approved and built in order to deliver the things that we know work. And if we don't prepare for 2027 and 2028, we will be caught flat-footed when preventions are shown to work. And so I think it's a profound opportunity that we all face, and I hope that we can communicate that clearly to the rest of the community, the leaders, the decision makers, so they can take action on it and do something so that we can prepare to help people out if prevention should work for the general population.
Thanks, Dr. Bateman. And I think we're going to hear more about that echoed through our recommendations too. So I think we'll get that reiterated. But thank you so much for the comments. We are going to switch gears. We're not doing a break. Sorry. But that was very fruitful and wonderful conversation, and I'm really pleased and honored to be part of it. So we are going to move now into the legislative updates. I'd like to invite Rachel Conant up, and she is going to be the first of 3 different legislative presentations. Rachel is going to update us on the ASAP Act. My thought as she's walking up to the stage is to tell you, one, this particular meeting is about research, but I thought it was very, very important now more than ever to also weave in some of the policy measures that are taking place as we talk about our members of Congress, and we hear from Dr. Bateman talking about the time being now. So I thought this was critical timing, and I really appreciate Rachel coming. She's been a colleague of mine, so it's a pleasure to see her here today. Welcome, Rachel.
Thank you, Michelle. Great to see you as well and to be with all of you today. It's really been an impressive 15 years since this council first met and we saw the first iteration of the National Alzheimer's Plan. And in my 15 years with the association, I never thought we would be at a place where we are now looking at screening tests. We have 2 FDA-approved treatments. We have lifestyle interventions and so much in care and support too, the guide model, everything that's happening with BOLD. We've made so much progress, but we know we have so much more to do. And so we're really excited today to provide just a few updates on where we are in Congress and where we're looking to get before the end of the year. And I also want to say a huge thank you. We have so many great partners in the community, LEAD Coalition with Ian and Courtney, Us Against Alzheimer's, Jim with Voices of Alzheimer's. And I don't want to start with like the Oscars and I leave someone off, but we do have a great community of folks and have brought so many new people in over the years. National Down Syndrome Society, for example. There have been so many great partners, so that's why we've been able to make all this progress. But again, much more to do. And I know we're here to talk about ASAP today and what I'm going to cover, but just a quick update, because I know the council has focused on this and really why we need to prepare our workforce. And just 2 weeks ago, the U.S. House unanimously passed the ADAPT Act, a great first step forward to make sure that we're training those primary care providers so that they're able to diagnose and provide those critical treatments if that's what families think is best for them at that time. And so we still have to go through the Senate, but it's a great step forward. And to see everyone in Congress support it in the House was a tremendous testament to all the work that our advocates and all of you here have done over the last year and a half or so to get us to this point. So now to ASAP. This is such an exciting time for us in the community. I have to say this morning's presentation, I did take out a few slides because we were going to talk about biomarkers, but the presentations this morning were spot on, perfect, and I knew I couldn't do any better than what I heard this morning. So you'll see a little bit of difference between what's on the screen now and what's online, but just phenomenal. Again, just a testament to the progress that we've made. And we're really looking at this time as an inflection point for Alzheimer's. We are calling this our mammogram moment. We saw when mammograms were covered by Medicare, screening rates soared. That early detection went from 14% of women getting mammograms to over 70%. And what did we see? We saw drop in breast cancer deaths, more treatments getting online, more access. And that's what we're hoping to see when we get ASAP across the finish line as well with Alzheimer's. And so we all know what the crisis is. We've talked about the numbers, how many people are living with the disease, more than 7.4 million. The cost to Medicare and Medicaid, $409 billion. 1 in 3 seniors are living with Alzheimer's disease. So we know what the scale is. We know what the impact is. We've all experienced it with our own families as well. And so we really want to talk about what is getting missed. And Dr. Bateman, I think you just set this up perfectly. What we're missing, those that are in MCI right now, fewer than 1 in 10 are actually getting diagnosed with MCI and are in that critical period where they can start those treatments if they think that's right with them. They're losing more time with their family, more time to plan, more time to really get into those lifestyle interventions that we're starting to see come online. And so we want to make sure that we're hitting that 9 in 10 that are getting missed right now. And that's where ASAP comes into play. And so these are some of the slides that I thought were deleted, but now we're going right into the ones that are going right to the heart of the matter. And we know we have the Secretary behind us. We were so welcomed with the news when Secretary Kennedy testified before Congress, saying that it's almost regulatory malpractice that we don't already have early screening for Alzheimer's. And so we welcome that comment, and we know we don't have to convince him with the recommendations today. We're hoping that that is included in today's recommendations. We need to focus on early screening for Alzheimer's. And so we know the barrier isn't not a scientific issue, it's a legal issue. Medicare cannot cover screening tests for those that aren't showing symptoms. And so there are 2 pathways to cover screening tests. One is through the USPSTF, either through an A or B rating, and the second is through legislation. And so that's the path we decided to take with the introduction of the Bipartisan Alzheimer's Screening and Prevention Act. And so we want to get rid of that barrier. And so first, we want to make sure there are 4 things that we cover that people understand. First, it's not a mandate of coverage. CMS will still go through their evidence-based process to make sure that it's warranted to be covered. The FDA still does their process to make sure that the test is approved. We also are not mandating that people take this or that doctors prescribe it. That's a conversation that has to happen between the patient and the doctor. And we also, it does not mandate a price. That is set through the CLFS. So just to make clear, there's still an evidence-based process. The bill is simply to remove that legal barrier so that Medicare can provide that coverage. And we've seen this action taken before. We've seen it that when Congress acts, we can see that uptake in other diseases. So Congress acts, the agencies, FDA and CMS, do what their work has to do, and then coverage is set to begin. Right now, the bill is set to start so that tests would be approved and covered on January 1st, 2028. For those of you here in Washington, you know there's a lot of sausage making behind the scenes, so that date may get adjusted. But by setting that date, that then gives time to CMS and FDA to go through that process. So that's why it's critical for us to get this across the finish line now, so that we give that time to CMS and FDA, and then things are online in 2028. And so that's why we're making such an aggressive push this year to get this done. And we've seen other diseases set the stage for this as well. As I said earlier, mammogram really is what we look to as our mammogram moment. We want to have that same kind of energy behind ASAP, and where we can get people getting screened earlier, and if they decide treatment is right for them, they can get on those treatments. We've also seen this with bone density in 1997, and most recently, and this is what actually ASAP was modeled after, the MCED Act. And so that passed just a few short months ago in February, the multi-cancer early detection test. And so they are in the implementation phase right now. So where does ASAP stand? So we are off to a tremendous start. Again, we have strong bipartisan champions, we have great support in the community, and we are sitting at 47 co-sponsors in the Senate. And this was just introduced in November. So the Senate, we like to joke, is the more deliberative body. And so to have 47 co-sponsors in just about 8-9 months is amazing. We're also at 180 co-sponsors in the House. And the one thing that you'll notice, it's bipartisan, because it doesn't matter if you're a Republican or Democrat, this disease impacts all of us. And so we have a strong showing in Congress in both chambers. We have great co-sponsors on the committees of jurisdiction, and we know our congressional champions are pushing us to get this done over the next few months. But what we really need to focus is with the committees. And so that's where we're really focusing our efforts right now. So when they get back in September, we can bring the bill forward, hopefully for consideration. And we're getting really close to a majority, right? So 47 in the Senate, we're about 13 until we beat that filibuster in the Senate of 60, and we're getting close to that 218 in the House. So we're reaching almost a majority in both chambers. And we know we have the American public on our side. Our advocacy affiliate, the Alzheimer's Impact Movement, commissioned a poll just a few months ago, and American voters want this as well. So when do you see over 90% of the American public agreeing on anything? But they agree on this. They want these screening tests. They want to have access to them. They want to make sure Medicare is covering them, and they want to make sure private insurance is covering it as well. So I know the recommendations are coming out today, and I know Rob spoke to everyone back in April, but we would really, again, we're so excited to hear the focus on early detection, and we really strongly recommend that ASAP is in the recommendations today and focusing on the importance of early detection and diagnosis. And just a huge thank you. We know because of all of our work together, the medicines are here, the tests are here. We just need this act of Congress, and let's go get ASAP done this year. Thanks, everyone.
Thank you so much, Rachel. Next, we have a gentleman that I just met just a little while ago. His name is Jim Taylor. He is with Voices of Alzheimer's, and he is going to talk to us about the Bridge Act. Thank you, Jim.
Thank you. I'm Jim Taylor. That's James Taylor without a guitar. I am delighted to be here. I lead a patient advocacy organization called Voices of Alzheimer's. I'd like to take a minute to introduce myself and our organization, as well as tell you about the legislation that we're supporting. The closest I've come to anything clinical is marrying two nurses, and one at a time, serially. And my wife, Jerry, was the CEO of the largest long-term care facility in New York City. And she gave me a graduate degree for dementia training in her remaining years, which was extremely useful for me. And now I try to share it wherever I can. We were very fortunate that Jerry was in the phase 1 trial of aducanumab. And we knew almost certainly that it extended the time we had to be advocates in the United States and across the country. So I passionately believe that every newly diagnosed individual with Alzheimer's should have immediate access to treatment. Jerry and I were among the co-founders of Voices of Alzheimer's only 4 years ago, so unlike the previous speaker who has such a long and distinguished organizational representation, ours is a brand new organization, and we appreciate being up here on the stage. Our mission is to bring the voice of the patient and the care partner more directly to discussions such as these. And I really want to shout out and thank you and appreciate being here. I also want to especially thank Mr. and Mrs. Waterhouse, Ray and Gina, yes, for being your permanent voices of the patient and the care partner and the courage it takes to serve on this body. And we really want to express our gratitude to all of you because our community is looking to you for the wisdom and the leadership to move us into a new era of Alzheimer's treatment and care. If you look at the board of directors of VOA, Voices of Alzheimer's, you'll see that half of our members are outstanding individuals living with dementia. And in fact, 2 of those board members who joined with a diagnosis of Alzheimer's recently discovered that although they have dementia, they do not have accumulated amyloid. And while this was somewhat disruptive for them personally, kind of for me, it marked the tremendous transformation of the Alzheimer's landscape since my wife was diagnosed in 2012. At that time, a diagnosis was a bleak sentence. There was very little hope in our community. That has been remarkably transformed by the incredible progress we have made in the last several years, and I have scientists here who I think, researchers who I think tremendously for that progress. We have treatment that extends our early stage life by 2 years, maybe more. We have an incredible blood test, a simple blood test that's a tremendous diagnostic tool and also maybe a predictor in the future, as Risa told us this morning. Hugely exciting times, and we must celebrate the progress we've made in the last few years. But there's so much more to be done. And we know that it is hope that keeps us going. As a symbol of hope, I wanted to wear my sunflower lanyard. You may recognize this. Every major airport in the United States and many airlines have trained all their employees to know that the bearer of this lanyard is someone who's not in a wheelchair, but they have a hidden disability. They may be someone with dementia or someone with Crohn's disease. And these people need a little extra time. They need a little extra care going through TSA and security. So this gives our community hope that we can continue to travel, because to live our best lives, we want to go see our grandchildren. We want to take those trips that are on our bucket list. So hope is so fundamental. Last week, I came down to Washington again to meet with the board of directors of Amtrak. And it's my hope that not only airlines, but maybe in a few more months, it will be the American rail system that endorses. And I want to broadcast the value of these as broadly as I can. I firmly believe that every patient deserves the right to share in this hope. And the fundamental cornerstone of this hope is that when the anti-tau drug is first approved, Risa, that every patient will have access to it. That will be a glorious day. But today, not every patient has access immediately to Medicare and the benefits of treatment. We know that SSDI, which was mentioned earlier this afternoon, does not give immediate access to the 200 million young onset, younger than 65 patients in the United States, because SSDI requires a 29-month wait, 2.5-year wait, in order to qualify for Medicare. I've talked to many young onset patients. They are among the most courageous and heartfelt stories that I have heard. And Dr. Bateman, thank you so much for the work you're doing with Diane to benefit the autosomal dominant community. These are patients who develop Alzheimer's in their 30s, 40s, and 50s. They can join research immediately if they qualify, but if they choose instead to have the FDA-approved treatments, they have to wait 29 months, 2.5 years. That wait might even preclude them from being eligible to receive treatment because it's only available in the early stage of the disease. So this is a serious impediment. We know that ALS, because of the rapidly advancing symptoms, was legislatively exempted about 20 years ago from the SSDI waiting period. VOA has designed legislation which mirrors the ALS Act, and it was introduced in the House in December, and it will be introduced soon in the Senate after the August recess. Us Against Alzheimer's, the Alzheimer's Association, and other dementia organizations have endorsed this legislation, as we, VOA, have endorsed ADAPT, ASAP, and the Change Act. So it's wonderful that you invited the three of us here today, because we are united in being here and asking you to move all the legislation forward, not independently, but together. What a wonderful spirit you brought to us today, and thank you for that. So I think this is a wonderful opportunity, and we do ask, as did the association, that you move our legislation forward. My wife, Jerry, was a homozygote, a double 4 APOE carrier. And she knew when she died 2 years ago tomorrow that her son and perhaps her beautiful young granddaughter, Amelia, lived at an elevated risk of developing the disease. So this is a very personal mission for me. Maybe you can read my emotion and know that my heart is in it, but I know that so many people in this room have also been touched by the disease, and I know that you are very committed also. I believe that it is my responsibility, and indeed our responsibility, to eliminate every barrier to treatment, whether it be regulatory, legislative, or endemic in our healthcare system. And I believe that working together, we can break down every barrier. But it takes the collaboration, it takes the great minds in this room to lead us there. So I hope that we will work together to build the realization of the hope that exists in our community, so that Amelia doesn't grow up in a world where she fears developing Alzheimer's disease like Grandma. Thank you so much.
Thank you so much, Jim. Next, we have Erica Sward from Us Against Alzheimer's. She's going to talk to us about the Change Act. Thank you so much for joining us, Erica.
Thank you very much for having me. I will click this over. Good afternoon. My name is Erica Sward, and I'm the Chief Advocacy Officer at Us Against Alzheimer's. While I've been at US for a bit over a year, I've been in patient advocacy for more than 20 years. As you all have been discussing, this is a very exciting time in Alzheimer's for early detection, treatment, and indeed hope, for which I am grateful, like so many of us who have been affected by this disease personally. 2 years ago, we lost my beloved father-in-law to Alzheimer's, and I am eager to make this disease a thing of the past. Just a few moments ago, Rachel spoke about how many individuals are missed with early diagnosis. But even before we can get a blood biomarkers test, we can look to primary screening, and all of this fits together so well. As many of you know, there is a cognitive impairment assessment that is part of it, both the Welcome to Medicare and the annual Medicare visit. However, currently, this cognitive assessment can be performed by direct observation. If we rely on direct observation, we're missing people for whom follow-up is needed and additional testing that can be done so that individuals can be eligible for disease-modifying treatments before their disease progresses. From my own personal experience with my father-in-law, I can only imagine that this is shared by so many in the room. My father-in-law turned things on quite well, especially with people who did not know him, and I think we have all experienced this, the fake it until you make it perspective for people living with Alzheimer's who very much look and act like they have no problems at all, but when you actually do a screening through a verified cognitive assessment, you can see firsthand what the challenges are with that. That's where the Change Act comes into place. And the good news is, and I sit here with Dr. Ling in the room as well, and knowing full well that our fee schedule comments are due in just about 6 weeks, although we're hoping to do some belts and suspenders here. There is bipartisan, bicameral legislation that is in the House and in the Senate that would require the use of a National Institute-identified cognitive impairment detection tool to be done in both the annual wellness visit and in the Welcome to Medicare visit, to get a validated test, to get a baseline test in all of this, so that that test is part of the medical record for the individual and can be repeated each year to know when further interventions may be warranted. While not exactly parallel, I equate in casual conversation the lack of a validated test being done in offices where direct observation may be used instead to looking at someone and determining the redness of their face to decide if they have high blood pressure or not. If we have a test that is validated by the NIA or others, and as we're getting better and better, it is the responsibility of our healthcare system to make sure that it is being used. So the good news is that the Ways and Means Committee actually passed this unanimously out of committee in 2024, and one of the big things that congressional offices always ask is what is the cost, and in 2024 it was determined that it was a de minimis cost, which is really important. So it's a minor move forward, but we all know that the legislation would make a huge difference if enacted. I want to just explain how it all kinds of fits together here. Change really is a change from primary prevention and screening perspective that can help, whereas ASAP really is a preclinical diagnostic effort, but they're complementary pieces of legislation that help together to lead to early diagnosis. And I'm going to continue to move along here in the interest of time, but just to say that I agree with my two predecessor speakers here that there really is strong bipartisan support for Alzheimer's research for these three pieces of legislation, and that there's a phenomenal opportunity today for the committee to move them forward with a recommendation that will go a long way moving into the future. And then finally, I want to take one quick second to mention that US is taking a wide view of brain span and lifespan with our upcoming summit. The time is now advocating for Alzheimer's policy for every generation. This will be an opportunity for us to continue a deep, meaningful policy discussion from risk reduction and prevention all the way through treatment, with at least 3 senators joining us to speak. So with that, I want to thank Michelle and NAPA for having us here to talk about legislation, and I wish that all of us can move forward with the opportunities that are in front of us to have these policies go down for success. Thank you.
Again, I just wanted to thank Rachel from the Alzheimer's Association, Jim from Voices of Alzheimer's, and thank you, Erica, from Us Against Alzheimer's. 3 very important pieces of legislation. We are a little behind schedule, so I'm going to save the questions if we don't mind. I know a lot of policy just got dropped on you. I wasn't sure if that was related to me, so I was just going to give her a minute. Okay, no, that's okay. But I think it's important to note that the council has been very reflective of the policy recommendations here today. So I think you're going to hear more about them come out during our recommendations as well. So I'm looking forward to sharing that with you. So we're going to go straight to innovation in Alzheimer's disease and interventions. And this is an exciting topic because we just, as some of you may have heard, the Alzheimer's Association's International Conference was hosted in London. So many dynamic and exciting pieces of research coming out of that. One of these is going to be presented to you by one of my favorite people. He hails from Jacksonville, so I'm saying that because I get to spend a lot of time with Dr. Ricardo Hanel. He is going to share a little bit about the REMIND study. It is fresh, hot off the presses, and I'm very much looking forward to hearing. You may have heard a little bit about that before when we talked to MMI, I think 2 sessions ago. So this is an update, a refresh, and a little bit of more new information. So with that, I'd like to welcome Dr. Ricardo Hanel.
Thank you, Michelle. Good afternoon, everybody. First of all, I have to say, as a cerebrovascular neurosurgeon by training, it's an honor to be here. I spent 7 years of my career at Mayo Clinic, and one of the Mayo brothers said, union of forces is needed to move things forward. I think this is union of forces, and so I'm humbled to be part of this. From the patient's perspective, patients' advocates' perspective, and the phenomenal team that you brought together here, Randy, I'm honored to share a little bit what we're trying to do to impact this. If you ask 100 medical students to describe where the lymphatics on the brain sit, you're going to see a lot of kids stumbling to find an answer because it's something that is essentially 14 years old when it was first described in Rochester, New York, compared to 1906 Alzheimer's disease beginning. This is our home. Those are my disclosures. So I'm going to share with you a little bit here the work of Jeff Iliff and all the basic research people that put this behind us, and that will serve as a substract to what we're trying to do with surgery. And my first comment on this is always, this is union of forces. You saw all the work deliberately presented, brilliantly presented today for early detection, modified lifestyle, and medical treatment. This is by no means a competition. This is synergetic. This is union of forces, and I'm a big believer on that. And somebody, as a neurosurgeon, that prescribes aspirin, Plavix, and Lipitor. No financial disclosures there. Primary lymphatics, there's no question today that we have a system on the brain that is well organized, and this came from basic research showing that from rodents to humans that we have a perivascular space very well organized that count on arterial pulsations to move, to clean molecules through the brain, rapid and even more rapid than when you're sleeping. I'll show you that. Why should we take our nice sleep and support the clearance of what I've been talking all morning, amyloid beta, tau, and others. So if you look at this demonstration on the originals of lymphatics, you see that the system is there. You see that the system is there playing from the surface of the brain. So this is an injection of a tracer showing from the surface to the depth of the brain. This is there. And to show, and I hope this plays, it didn't. Can you click on the videos for me? So just to show the importance of the cycle of asleep and awake. If you can click on the blue for me, because I cannot do that here to start the videos. Here we go. Click on that. So this is the awake brain. You don't see much movement. Click on the lower one, please, sir. Thank you. And this is when the animal is asleep. And you see that all that lymphatic function is happening when the animal is asleep. And this started on the animal models and wait to awake brain and a sleep brain from where we are on humans. So bear with me because there's I cannot read that far, even with these guys helping me. So we know there is a lymphatic system contribution to clearance of amyloid beta and tau protein, and you know that this lymphatic function is impaired by known genetic risk factors, aka aging, and we have evidence for that. So this is the work of Jeff Iliff showing that lymphatic system does contribute for amyloid beta and tau protein, and we see this on the aging brain first in rodent, and you see here the difference. And you see here the difference on the aging brain on the right side versus the left side. And we know that we can see this when we knock out these models, and in animals we can do that, we can do genetic modification and change the aquaporin number 4, aquaporin 4 molecule. If you delete that from these animals, you basically are impairing a lot of this lymphatic system. And you see that if you create these animals without aquaporin 4, they will develop dementia much, much faster. So with that, we can measure this, and I'm going to skip through this for sake of time. We can measure this in MRI now. Very, very eager to hear about Michael's research on DTI and Down syndrome with Alzheimer, but we see that this is there and is demonstrated also in humans. And you see this work being done by Jeff Iliff, showing that this difference on this awake brain and a sleep brain in clearance of these proteins on patients with Alzheimer, sleep-deprived, or patients that have not been sleep-deprived. That brings us to where we are with surgery. We know that we have this system lymphatics on the brain, and we have these anterior and posterior lymphatic systems that are demonstrated, and could be that clogging of this system lead or worse Alzheimer's disease. This is one of these questions that we have in medicine: is the chicken versus the egg? What comes first? Is the tangles clogging the system, or is the system decaying over age? So this is started in China by a colleague named Professor Shi in Hangzhou, where he started doing the surgery with a very small incision on the neck of these patients, connecting the lymphatic system from the neck, that is the base of the lymphatic system of the brain, to the external jugular vein. So essentially creating a fistula, increasing the flow, enhancing the flow, augmenting the flow of the lymphatic system to clear these proteins. And then demonstrate this in patients with Alzheimer, decreasing amyloid beta deposited on PET scans. And we have watched this over 2 years, a multitude of surgical series coming on the literature demonstrating improvement on these patients on cognitive scales and markers on that, all from abroad. And this came to a point that the Chinese government asked doctors not on clinical trials to stop doing treatment because this should be done under clinical trial. This is the largest series, nothing compared to mature medical testing medications that we have with thousands of patients in one arm versus the other. This is a very early stage. We're talking about single arm, hundreds of patients being done elsewhere. And you're going to see the minuscule number of patients that we have done in the U.S., but you got to start on the right foot inside the umbrella of clinical research, very, very well vetted and scrutinized as it should be. But this series from China show that on these 139 patients with severe, everything that we talk is mild, the earlier the better, maybe treat symptomatic patients in the future. We're not there yet with this. We're just measuring, and this is results for severe patients. And on the last couple of minutes here, I'll show you that maybe, like a robot, have changed many surgical areas of the field, like prostate, cardiac, and others. Maybe with a surgical robot that we can put smaller vessels together in a more precise way, maybe we can make an impact on this disease. This robot, can you click for me, sir, on the corners there again, just to show you? This is a hand-free surgeon with big hands, sleep-deprived, cough in the morning on the left, and on the right is the robot filtrating the tremor of the surgeon in spite of the multiple adjectives that I told you, and thus decrease the motor scaling that we have there. So this is the surgeon sitting on the left and the robot working on the right. We're working on many applications. This is an FDA early feasibility study that we're doing in Jacksonville with my colleague and a dear friend from Buffalo, Adnan Siddiqui. We have enrolled a couple of patients on this study for a different disease named Moya Moya, and I'll focus the last 5 minutes here on the remind. And I'm very glad that we start this with the rubber stamp of an FDA early feasibility study in the United States. We have to measure, does this work, doesn't work, where does it work? The Remind study is an early feasibility study to measure first the safety of this. We got to prove first that we're not hurting these patients over 50 with a general anesthesia surgical procedure, and that's the #1 objective for the study. So Yale, Stanford, and us in Jacksonville as part of the study. And here you see the objectives, inclusion, exclusion criteria. I'm not going to bother with that, but very, very scrutinized with blood markers, CSF markers, PET scan, and multiple cognitive studies assessing these patients. And I'm very glad to share that we enrolled the first 3 patients in Jacksonville earlier this year at Baptist with my colleague neurologist, cognitive neurologist Steve Tanges, and my colleague plastic surgeon Michael DeFazio. We operate 3 patients with Alzheimer, 2 with moderate disease. The medications do not apply for them, as you guys know, and 1 patient with mild disease, 1 homozygous for APOE4, and 2 heterozygous to that. With about 4.5 hours per patient, we do bilateral anastomosis, so about 2 hours per site. The end goal is to do this under local anesthesia, maybe as an outpatient. All 3 patients went home the day after. None of them had any clinical serious adverse event complication. And those are from the study. We do high-frequency ultrasound to map activity of the lymph nodes, and it's part of things that we have to learn who is developing disease, and maybe on the asymptomatic patients, who is decaying lymph node function. We see here an intraop, so we inject indocyanine green as a green dye on the nose, and we inject a yellow dye, so we're measuring both anterior and posterior pathways of lymph nodes, and we checked that during surgery. And it was an aha moment when I saw lymph going from the lymph node to the vein. So the fistula does work. I saw that first done in Korea. There was not great contrast. When I saw done at home, I said, I think we're into something here potentially. So this you see here on the right side, the video of the yellow dye going from the lymph node to the vein. This is the poster that we presented at AIC. Was my first international Alzheimer conference. Impressive to see 11,000 people. Cerebrovascular, when we have a big conference, 1,000 people. On average, it's 500, so we're nothing compared to Alzheimer. I'm very, very glad to share that FDA gave us green light to proceed with the next 12 patients on the early feasibility. So we got the rubber stamp that this was safe for the first 3 patients, and we're enrolling 12 more. And our hope with those 15 patients, we can learn and go to a bigger phase 2 study, hopefully with 200, 400 patients. We're about to start a 50-patient study in Europe with 5 sites in Europe with a very similar protocol. I have no question there's a lot to be learned here. Again, I'm humbled to be learning from you guys and bringing this home. I think this surgical procedure is simple, is safe. Are we changing the outcome of this dreadful condition? I think the true and open answer is we don't know, but no place better than a clinical trial to measure that and to educate, learn, and inform what could be the next steps. And maybe surgery in the future will be part of your armamentarium when our primary care physicians, neurologists, and practitioners seeing patients with disease. What do I have to offer to these people? Maybe surgery will be part of that. Again, Michelle and team, I appreciate the opportunity to serve on this council, and I think we have some time for questions. Thank you.
I love that we're hearing from innovations from every different space of research. So this has been an exciting day. Do we have time, Maria, for a question or two?
Yeah, we've got about 4 minutes.
Oh, good. Perfect. We're ahead, y'all. Okay. Any questions from the council for Dr. Hanel? I know that was, again, a lot to digest.
quick question. So I'm excited that you have the biomarkers and the PET imaging as part of the clinical study. What are the primary outcomes? Is it mostly safety-based? Are you looking for amyloid clearance, or what is the trial intended to do?
So this 15, thank you, Randy, for the question. This 15 patients, the base is safety, but we're measuring all a bit cut and paste, copying what you guys did in neurology for the clinical trials for this disease. I think it's very important to see, and one of the biomarkers is very interesting to see that metabolites of tau and amyloid beta on the blood decreased significantly in some of the previous surgical cohorts. So we're measuring all that. We start the original protocol, and the beauty of being under an FDA early feasibility that you can titrate and adjust things. So we start with baseline and 6 months, and we just got approval from the FDA to go for baseline 3 months and 6 months. So a change on the protocol, because I think it's very important to measure this. And ideally, if the patients, they signed this, you know, in clinical research, they signed the consent first day. At 3 months, offering a lumbar tap is not a pleasant, but everybody signed for a lumbar tap at 6 months, and on the new amendment at 3 months. So the idea is to have all these markers, blood, CSF, and PET scan for everybody at all time stamps. It's a lot for the patients, but I think because it's early, I think we've got to measure more.
Go ahead, Mary.
Is this something that has to be done more than once for a patient? Is this an ongoing kind of treatment?
That's a great question. We're discussing earlier, I wish we had, and this is a work in progress, a great imaging system for our lymphatics or lymphatic system. We don't. So we are developing and working on that in parallel. How do you measure the function of this lymphatic system on the human brain? It is a work in process. So as of today, the surgery is done once, and we're measuring the results of that up to 12 months. But we don't know that answer. That's a great question. A lot to be learned.
Any other questions? Okay, well, for one, I'm reassured by listening to our researchers and clinicians and scientists who have deep hearts for this. So you're just seeing a lot of tremendous enthusiasm and engagement from science and from policy, as I mentioned. So we're going to take a quick break. We're going to come back and listen to recommendations. So a lot to come, very exciting stuff, and we'll see you in about 5 minutes. Thank you.
Produced by the U.S. Department of Health and Human Services.